This week on the BackTable podcast.
For the last years, everyone followed the rules of 5, like 50% arc, so 180 degrees of calcium arc, greater than 0.5 millimeters of calcium thickness, which you can measure in OCT, and the length of 5 millimeters. But there is a recent publication from this year where the rule of 5s is changed to the rules of 3s, which makes life a little bit tougher, but it isn't. You're giving points now for calcium arc of 270 degrees. This is the complete population in this investigation. You get 1 point for concentric calcium, so 360 degrees of calcium is giving 1 point. And then there is thickness of 0.3 millimeters is giving 1 point over a length of 3 millimeters. And if you have 2 or 3 points, the risk of stent underexpansion without special treatment is much more higher. So you should use your high pressure balloon, your cutting balloon, your IVL, or use atherectomy itself.
Hello everyone, this is Hady Lichaa from Ascension St. Thomas Heart in Murfreesboro in Nashville, Tennessee. It is really a big pleasure and distinct honor for me today to get our first international guest, who is the super talented Dr. Erik Rafflenbeul. He is from Hamburg, Germany. He works at Schön Klinik, Hamburg. He is world renowned for his educational skills, and there's barely any week where he's not at a conference educating tons of people on the most, not only in imaging, but all aspects of modern interventional cardiology. We entitled this episode Illuminating the Vessel, the 2025 update on intravascular imaging in PCI. And it's obviously for cardiologists, interventional cardiologists, fellows, and cath lab professionals. Welcome, Dr. Rafflenbeul.
Yeah, thank you, Hady, for having me. So it's a huge pleasure being here and being an international guest and not a foreign speaker, but I hope we'll get through this. And talking about intravascular imaging is even more important to me because I'm a doctor on intravascular imaging. I do complex PCI, I do modern PCI, precision PCI, whatever you call it's not important. But one thing is important, and this is the why to use intravascular imaging and why to do complex PCI properly. And I hope we can talk about intravascular imaging. And after the episode, everybody will adopt a little bit more because numbers are not that good even in the United States. So let's talk about this. I'm looking really much forward to this.
That's awesome. Erik, before we start, I thought I would give you a chance to kind of let the audience know about your background and how you got there.
Yes, so I'm an interventional cardiologist, as you told, in the most beautiful city in Germany, which is Hamburg, second biggest city after Berlin. I'm head of cath labs here in my hospital, and besides this, training fellows and consultants which are with me and training me every day. I'm also have a position in the European Society of Cardiology and the association which is dedicated to interventional cardiology, which is EAPCI, and there I'm chair of the educational content courses and webinars committee. So as you can hear, I'm really much dedicated to education. As I told you, education to others, but you have to educate every day by yourself, right?
Absolutely.
Because life can only be understood backwards, but it must be lived forwards, right? So, and this is also in life and in interventional cardiology, never stop learning.
And currently, before we start talking about intravascular imaging, what's the current state in Germany specifically and in Europe, since you travel around Europe all the time? In terms of percentage of use, what's the range of use of intravascular imaging in general in Germany?
That's a good question. So in Germany, we are collecting data which is 2 years old, which is in the heart survey done every year, but looking back at 2 years. So we have data on 2023, and the percentage is super low in PCI. It's 6.4%. The use of intravascular imaging in total PCI. We are kind of world champions in coronary angiography and PCI, but we are not world champions in using of intravascular imaging. So there is one country even being worse than Germany according to numbers because intravascular imaging is not reimbursed, which is France, for example, with less than 1%. But there is countries much better than Germany, like United Kingdom, 25 to 30%. And there is a publication on Javier Escanet, published on JACC, which all the numbers. Japan is up to 90%. As we all know, United States is 15%. But I think it's not all about the numbers of the countries, because there is people like me doing over 80% intravascular imaging guided PCI, and there's people doing 0, and there's people doing 50%, or maybe this 6.4%. So we have to make it more homogeneously, and this is all about education. I'm sure it's much about education on this topic.
Absolutely. And so let's start with why. So I'm a busy interventionalist doing, let's say, 200, 250 PCIs a year. And, there are 6 cases on the schedule. Some of them are complex. Why should I bother?
So the easy question is, because guidelines are saying this. Until 2024, the CCS guidelines of the European Society of Cardiology recommend intravascular imaging within 1A recommendation in complex lesions. They are saying particularly long lesions, left main and true bifurcation. And if we look on the European recommendations and guidelines on ACS, they recommend to do intravascular imaging in ACS with a 2A recommendation. But the American guidelines and AHA recommend, like in CCS, the European guidelines within 1A recommendation. So there I can do a mic drop and say, this is all enough. Think about your prescribing a medicine which is 1A recommendation. You don't do this. Major fault, right? And if you don't do intravascular imaging in left main PCI or true bifurcation, long lesions, and you can talk about other scenarios where I think it's also 1A, and we will talk about this, you're doing a major fault, in my honest opinion, according to guidelines and according to treat our patients better.
Absolutely. One of the major weaknesses of especially the health system in the US, is the fact that if someone presents 35 days after a PCI with a stent thrombosis, or 3 months after a PCI with in-stent restenosis, this does not count against the operator or the hospital, which is something that I think would definitely help in optimizing the use of intravascular imaging. If there's something we shine at, it's to minimize target vessel revascularization, at least within 1 year. So do you follow patients like that in Germany? That if someone presents 2 months after a PCI, would that count against you?
There is no penalty, but I think there should be something like a penalty, because in Germany, I think the system is different from United States. So 90% have general health insurance in Germany and 10% have private. So talking about the 90% general health insurance, they pay the hospital or the insurance company by diagnosis-related groups. So it's just about the diagnosis. If it's CCS, ACS, whatever material you use is in this budget. But in CCS, intravascular imaging and physiology are with the same amount specially reimbursed. So if you use it in the scenario of chronic coronary syndrome, you get special money, extra money, which is not big money, but at least is covering the price of the catheter, or if you talk about physiology, the pressure wire itself, which should be fair enough to use it and to use it. But there is no penalty if you cause stent thrombosis, target lesion failure. There is no, but in my opinion, there should be a change in this system to make more efforts to use it and to have better outcomes, which less stent thrombosis. This is where the studies are enormous. 50% of reduction of stent thrombosis, which is often a lethal diagnosis.
Absolutely. So I thought in the why I would incorporate 2 more elements that we need to discuss. So the first element is obviously what you mentioned at the beginning, the reimbursement, which hopefully with the guidelines advancing will push the payers to actually approve of that. The 2 other elements is, number 1, the speed and efficiency of the procedure. So someone really gets scared 10 years into practicing based on angiography. Now they're going to have to pick up on a new technology that slows them down. From your experience seeing cardiologists in the middle of their career picking that up, how long does it take? How many cases does it take before someone can get used to it from a lab throughput standpoint?
Let's look at the perspective of the whole team, right? So it's not just about the operator, it's about cath lab staff and nurses. So if you have it you don't have it integrated in your cath lab table, in your display, like example OCT or IVUS, whatever. You have to bring in a console, right? This is a thing, you have to pick it up, you have to plug it in, you have to get the catheter. So this is all what makes it, when you start your program, less efficient for the time for the PCI. But if you train all your team, maybe also about image acquisition and image analysis. So this is a huge thing. In my honest opinion, it's not only about the operator. But as you told, if you're doing PCI for 10 years, 20 years, doesn't matter how long you do it, and you do it like all the time in kind of the same thing, you have to adapt, and there is a learning curve. And I think the learning curve is 50 to 100 cases.
No, I agree.
So I don't like to be too dogmatic, but be pragmatic. And we will talk about this. You have to find your algorithm for your cath lab and how you use intravascular imaging in diagnostics. So pre-PCI, during PCI, and after PCI, if you put a stent or put a drug-eluting balloon to check your result, right? So because you have it now, then on the table. And this costs a little bit of time, but there is no clear data showing that it's more radiation time. Yes, when we talk about OCT, it's a little bit more amount of dye you use. But there is no data that you're harming yourself with more radiation and super much longer time of the procedure time itself.
And honestly, from my personal experience, just the more you do it, the more your staff becomes chop, super fast at it. And, 50 to 100 cases now that some of the other interventional cardiologists that I saw pick up, it was much easier for them when the staff is super educated and fast at it. And the third element I would like to address in the why is the fear of not knowing what you're looking at. So you have someone who is extremely confident in PCI, who's been doing it for a while. Now they're getting an image and they have almost no idea what they're looking at in some aspects. And that adds a lot of medical legal pressure, a lot of issues with being confident about it, and honestly about adopting it. Also, how would you address that, and how do you think interventional cardiologists have overcome that major obstacle?
You will see it there. You need less cases for this to see that this is making your results better. You're using stents different. You're using pre-dilatation balloons different, because you will never put in an proximal LAD a 2.75 stent, because this is not existing.
Right.
So you will recognize it not with the luminogram of the angiography you have done for years, but you will recognize if you see the morphology of the lesion, the morphology of the vessel itself, that you have to treat it differently. Yes, maybe at the beginning you stent way more longer. So also studies showing that you stent longer from proximal to distal reference healthy lumens vessels, yes. But you will see that yet you do it differently. But what is making life hard, and I do a lot of educational courses on this topic, is people see, I have this IVUS eyes, or I have OCT eyes. No one is having OCT eyes without ever using OCT before. If you use OCT or IVUS, you are even getting better if you don't use intravascular imaging, in my honest opinion, because you react different to angiography. But for me, it's hard to say not to use intravascular imaging, because in the introduction, as I told you, I'm using more than 80% of all my PCIs intravascular imaging.
Excellent. So after we got through the why, now what are we going to be using? So IVUS versus OCT. Tell me an operator, obviously a lot depends on contracts and availability and all that. But let's say someone has access to both. Which one would you pick in today's practice, and why?
Yeah. First of all, if you have access to both, congratulations. Then you're quite safe. To be honest, I at the moment have only access to IVUS, which is fair enough, and I will explain why. But what is the difference? So most of the difference is where the source is coming from, right? It's intravascular ultrasound, so it's an ultrasound probe going in a catheter or doing a manual pullback, which the Philips Volcano system, the Eagle Eye, which you can manually pull back, which is good to do this. It's not running in a catheter itself, the IVUS lens or the IVUS probe. And then the difference is there is OCT, which is light. And the major difference is that you have to clear the vessel, all the particles, which is erythrocytes and thrombocytes, which die with the fluid, to get rid of it because it's reflecting the light. And the major thing in OCT, it's coming with light, so it's a light source running in a catheter. And the thing is, you have to clear the vessel. You have to clear erythrocytes and blood from the vessel to have no reflections from blood. And the positive thing is you have a much better axial resolution, spatial resolution, which is 10 to 20 microns. And compared to HD IVUS, it's 20 to 40 microns. So you can see much more bright. You can see even tissue macrophages, see inflammation, see erosion, and this is what it makes hard in HD IVUS to see. But talking about publications on this, there is the OCT-IVUS investigation comparing both things, and nothing beats the other one, right? According to target lesion failure, etc. But if you are in a scenario of acute coronary syndrome and you have an ambiguous scenario where you don't have a plug rupture or you have an intermediate lesion, and if you put in an HD IVUS, you're not able to see erosion. Maybe you see a rupture because of the spatial resolution in OCT. You can see erosion, you can see a thin cap fibroatheroma, ACS, or a rupture of a thin cap. This is the most thing where OCT is maybe better to have. So it's good if you have both, but if you have one, you have to be good in using it.
And when you say HD IVUS, could you tell us a little bit more about that? HD standing for high definition versus regular definition?
So it's just about the hertz, right? So it's the standard definition IVUS, like the Volcano system, the Philips system, the Eagle Eye, is coming with 20 megahertz, so less spatial resolution. And there is HD IVUS with 40 or 60 megahertz, for example, from Boston Scientific, the Optical catheter. And there's different other companies. Even more companies are coming from China and India, and there is Assist bringing a device. So there is the opportunity to have this technology, and I would suppose if you buy something, your CEO is giving you money and you don't have intravascular imaging, or you have to renew, by HD IVUS, so 60 megahertz.
You know, in these episodes, we like to be practical, everyday interventional cardiology. What do you like about the Philips system, and what do you like about the Boston system?
So what I like about the Philips system, it's really intuitive, right? You plug in, it's plug and play. You have the system, you pull it, you bring it to the lesion over the wire, and you don't have to bring a catheter in, and you don't do an automatic pullback, which takes time for image acquisition. And you can go on places and leave the IVUS probe there where you want it to leave. So this is super beneficial in CTO procedures. You can even go subintimal to see, or you can do it in bifurcation PCI, putting the IVUS probe at the level of the bifurcation if you want to nail the ostium, right? So I would never do this again without intravascular imaging. So this is why it's really easy. But the resolution is not that good, right? You have not this crisp use, but you can follow an algorithm which is looking mainly on morphology, lesion length and diameters. You can really good see with the Philips system. And another thing on the Philips system, if you have it, you can do a code registration with your system, with your angiography, and you can go back and mark where lesion length is, where you are with the IVUS probe, and even do tri-registration with physiology. This is a major thing which Philips is coming, so doing it with IFR or FFR combination.
And can you tell us what you mean by co-registration for someone who's not familiar with that?
Yes. So it's the comparison of the IVUS picture compared to the angiography. So you do a co-registration, you not automatically pull back, you do a manual pullback, like 1 millimeter every second. You can be a little bit faster, and it's co-registrated where the position of the probe was in the angiography. So then you can look on your lesion, and you can measure how long the lesion is and where this spot in IVUS is in the actual angiogram. This is co-registration.
Absolutely. And I feel like when interventional cardiologists are starting to learn this, the association between IVUS and where that corresponds on the image is a massive benefit. Sometimes you get lost. Obviously, with an experienced operator, you're pulling back. Let's say you're using the Philips system. In your head, kind of where you're at. Sometimes you cine, dry cine, where the catheter is when you bookmark, etc. But knowing that interaction between angiography and IVUS allows you to expect lengths, expect positioning, and all of that. Now, on the Boston side, what do you think besides image acquisition, high definition, what are the pluses of the Boston system?
So the plus of the Boston system is definitely some kind of artificial intelligence that it's, even if you're starting, so with the Avigo Plus system, you have this automatic lesion assessment where the system helps you to measure where there is plaque burden, how much plaque burden, and it's doing automatically the lesion lengths because of the pullback, but without co-registration at the moment right now. But the system is helping you to show you on the IVUS where there is a lesion, where there's the healthy part, what is the minimal lumen area in this area, what are diameters. So this is a big plus for the Boston Scientific system. It's still developing and developed over time because the pullback speed increased without losing too much information. So this is super important if you have a long lesion. So with the Boston system, you can 15 centimeters do a pullback. But if you have to stay there for 1 minute to do this pullback, sometimes it's annoying because you want to be fast, but with this advanced pullback speed, it's even getting you much more speed and speeding up your PCI even.
Right. And I love the fact in their new system, they actually gave you 4 different kind of choices for the pull-up, pull-back speed. The 8 millimeters per second is pretty fast.
Yes,
now,
it
obviously, it saves you a lot of time, but of course, you're missing some detail. But if you have 100 millimeter lesion that you're trying to get through, you can't get at 1 millimeter per second. It takes a long time. Now, in terms of zero or ultra low contrast PCI, do you feel like the length estimation by the Boston system is a plus to give you a length of a stent without even puffing?
Yes, it is. Because the system, the co-registration by Philips, you have to do an angiogram. You can trick out the system. If you have one angiogram, you can use it in all the same scenarios to do the pullback even there without doing an angiography afterwards. So which needs 6 milliliters or 4 milliliters of contrast. You can avoid this with the co-registration, but the Boston system is definitely a plus that you don't need put additional dye to do a co-registration.
And in terms of the catheter crossing profile, which one do you think is better?
In my honest opinion, the Boston system is a little bit better, even if it's coming in a catheter itself and it's the pullback in this catheter. The EGI Platinum is a little bit more bulky. But when I am not able to cross a lesion, I know in 99% it's calcified. So you have to think about what can you do to treat this lesion up front before you do an imaging, because this could be a pitfall that you cannot cross with your IVUS probe or your OCT probe. Then you really much know what the enemy is, but then you are not stopping. So then you're trying to get your way through and then doing a picture on OCT or IVUS to do it. But according to your question, the Boston system is really good to cross lesions, but I never force, because when you force to go with just to do an IVUS or intravascular imaging, to have this pre-procedural setup, you can also cause problems with this.
Absolutely. So now you got your picture with whatever system you have. Walk us through your fast kind of way of dealing with the information and the 3 most important things you're picking up from the IVUS to make a decision about your interventional strategy.
So as I told you, don't be dogmatic, be pragmatic, but you have to follow an algorithm you have to choose. And all the manufacturers are coming with different algorithms. So talking on IVUS, you can have this 1, 2, 3 IVUS algorithm coming by Boston Scientific. And if you talk on OCT, there's MLD Max. So you have to start with pre-acquisition. So if you check the lesion before PCI, you have to check. And the first thing is ever look on morphology. Look on morphology starting with lipidic, fibrotic, and the worst enemy of an interventional cardiologist and for every patient then is calcified lesions. So look on this. And talking a little bit on calcified lesions, not Calcified lesion is not a morphology in itself, so it could be eccentric, concentric, or nodular calcium, which is really important then to decide which calcium modification you're doing afterwards. If you see truly lipidic lesion have an end STEMI, you can go up front with direct stenting. It's possible to do it. I don't do a direct stenting in most of my cases, but if you have a scenario with a STEMI or end STEMI, true lipidic lesion, plug rupture, you can go with direct stenting. Why not? If you have fibrotic, you have to think about if you're doing cutting balloon or other things or high pressure balloon, PTCA. But first thing, look on morphology. And the thing is, if you compare the different things like IVUS, a thing which is not good on IVUS, you cannot see how deep the calcium is, right? You cannot measure depth. But you can estimate if it's deep or superficial, because if you have reverberation, this mirror artifacts, like you have in echo, in normal echo investigations, you can assume that this is superficial calcium. But if you have pure shadowing, you cannot see if it's superficial or deep. Maybe it's most of the times more deep calcium, but you cannot measure. This is different from OCT, where the light is traveling through the calcium blocks, and you can measure how deep the calcium is.
Why is that important, superficial versus deep?
Yeah, it's important because this is letting you choose what the calcium modification tool you're using you should use. So there's different algorithms on this. Talking on OCT, for the last years, everyone followed the rules of 5, like 50% arc, so 180 degrees of calcium arc, greater than 0.5 millimeters of calcium thickness, which you can measure in OCT, and the length of 5 millimeters. But there is a recent publication from this year where the rule of 5s is changed to the rules of 3s, which makes life a little bit tougher, but it isn't. So you're giving points now for calcium arc of 270 degrees. This is the complete population in this investigation. And 1 point is, you get 1 point for concentric calcium, so 360 degrees of calcium is giving 1 point. And then there is thickness of 0.3 millimeters is giving 1 point over a length of 3 millimeters. So, and if you have 2 or 3 points, the risk of stent underexpansion without special treatment is much more higher. So you should use your high pressure balloon, your cutting balloon, your IVL, or use atherectomy itself. So this is why it's important to differentiate between superficial and thick calcium. Even when you're talking on debulking, so I think a major aspect where debulking works is superficial calcium, because it's ablating the superficial part of the calcium. But if you have super deep calcium, the rotablator is maybe not reaching. You can discuss over hours, and you have a BackTable Cardiology episode on calcium modification itself. So, but how are you doing it? Is the depth one of the major parts when you do OCT to decide which calcium morphology or which calcium modification tool you are using?
Exactly like you said. So the superficial calcification, I favor atherectomy over IVL. Deeper calcium, I favor IVL. Obviously, there are some exceptions to that with the eccentric nodules that are non-eruptive. Sometimes orbital atherectomy can really shave through that pretty deeply. But in general, to reach the deeper layers, IVL has been really amazing with some exceptions. But so to summarize what you said, the first aspect of IVUS that you look at very quickly, we're talking seconds here. Within 5 seconds, you have an idea. The morphology, you said lipidic, fibrotic, or calcific. And if it's calcific, based on the rules of 5s or 3s, depending on what you use, now you're going to decide, am I going to use a calcium modifying tool versus I'm going to just use a non-compliant balloon or a scoring balloon or a cutting balloon. So you see within seconds, now you have very fast decisions being made that will optimize your long-term outcome. Now talk to me about diameter and length.
Yes.
How do you think about that, and how do you measure it?
Yeah. So these are the last things, the two things out of three things you do pre-procedural is lesion length, which is important. So it's a little bit tough to when as we talked about, if you don't have co-registration and you do a manual pullback with the Philips system, I do a cine where I start with my probe, and you have every 10 millimeters you have a marker on this IVUS probe. Use it to measure. Even without dye, you don't need it. And what I do if I don't do co-registration, I pull it back, and if I see something on the IVUS when the lesion is starting, I said bookmark to my nurses. They bookmark. I do a short cine and I pull back. And if I have regions of interest like plug rupture or different calcium morphologies, I say bookmark and I cine. So there I can evaluate what the lesion length is. The Boston Scientific system and the OCT system is giving you the direct length in the system itself, because it has a defined pullback speed. So this is important, because talking about diameters, you want to then, or a lesion length, you want to stent in lesions less than 50% plaque burden, which is important. So a pitfall of OCT is that you cannot measure plaque burden itself, because it's the ratio of the plaque in the according to the volume of the elastic external lamina and the volume of it. So OCT cannot directly measure plaque burden, but IVUS can. So, and you want to stent from healthy to healthy landing zones with which less plaque burden than 50%. This is important. And talking about diameters, you're choosing the diameters which are less diseased. And you choose stenting from normal to normal, and you're searching for the media itself, right, for the elastic external membrane, and this is what your reference diameter should be.
And this is where all the training is all about, to recognize where that is. Now, I've noticed an early adoption when people are super excited about intravascular imaging, they have the tendency to oversize. Have you seen that? Do you tell your fellows or your colleagues to get that distal diameter? Do you undersize a little bit to that, and by how much?
Yeah, it depends. So in really diseased lesions, you have the vessel is getting bigger, right, itself, but it's not where the elastic membrane is. So, and you have not to force it, because you can cause perforation and you can cause dissections. So you have to find a way where you have a crisp view in a healthy lesion, where you can see this black arrow or this black circle. You can use your stent according to this side. If you have lesion and you can barely see, I downsize a little bit, but never size according to lumen, right?
Of course.
Because this is what we are doing in angiography guided PCI. We have just a luminogram, and because according to lumen. So if I cannot see the elastic membrane very well, for example in calcified lesions, I downsize my stent and my balloons 1/4. And if I can see it, I put it there, and even you can upsize a little bit.
Absolutely. That's great. I love the fact that practical aspects, you go in, nothing is really semi-normal. So you go a little bit more distal, you come back more proximal to have an idea where the vessel starts becoming relatively less diseased, and you measure based on that. And obviously, when you're measuring, you're taking things into context. So a proximal circumflex or a proximal LAD is almost never 2 or 2.5. Even in the smallest women on earth, you can never see that. So if you end up with this number, something's not right. So in your mind, the proximal vessels are closer to 3.0 and the distal vessels are closer to 2.5. Rarely 2.25 or 2.0 if you're doing DCB. So I take that into consideration. So when I'm measuring and my diameter ends up being 4.2 in a distal circ, I take it into account. I don't want to use a 4 millimeter balloon there. I'll take a 3.5. So there's a lot of judgment call also that comes into that.
Yeah, definitely. So reverse remodeling is an important aspect you have to consider in. So because this is when you're starting that you're using too big material, but even in left main, nobody can say if the left main is 6 or 5.2. In small vessels, you can estimate by angiography how big it is. But if the vessel is getting bigger, so you cannot clearly estimate. And you see where you put a 4.0 stent in a left main, maybe it's 5 and you have malposition. This is a learning you get from intravascular imaging really, really fast, that you're causing malposition, mainly malposition in big vessels like proximal LAD, RCA, or left main.
And I love the fact that you dry cine when you're pulling that, so that gives you an estimation of the length in the Phillips system. That is a super helpful tip. And now, in terms of diameters, let's say you have a large discrepancy between the distal diameter and the proximal diameter. Let's say you're doing a left main to LAD, and there's a 1.5 millimeter difference between the distal and the proximal. How do you choose your stent based on that? And do you factor in the stent properties when you're doing that?
Yes, super important aspect. Always choose your stent according to the distal reference diameter. So even if you have a lesion and you have a 48 millimeter stent, which is going from the LAD and covering lesion LAD up to left main, so you have to think about what your overexpansion capacity of your stent is, right? So, and the thing is, if the left main is always a bifurcation, right? So the vessel is tapering. We know this. And if you do it by angiography, you can use Finnett's law, right? And you use it, and it's quite accurate according to intravascular imaging to let you know. But if you do this, so for example, starting with a 3.0 stent or 3.0 diameter in the LAD, and the left main is 5, so you have to know your stents. So I have more than one stent manufacturer in my cabinet, in my cath lab, so which is Boston System, Boston Stent, the Synergy, but I have also Megatron, which is a no-brainer because it's always, the stent itself is a 3.5 stent, but it can go up to 6. So if you have it, you don't have to think much about if you're 3.5, what the overexpansion capacity is. But for every stent there is tables, and coming from EAPCI and other associations, and you have this from Sky, there is tables for every stent what the overexpansion capacity of every stent is. So take this into account. This is super important because you have to pot then in the left main, choose your pot balloon accordingly, but you have to know what your stent is able to go up. But because if you go bigger, you damage your stent, the connectors are failing, and the stent is losing all its radial force, so causing a lot of problems, which you can see in angiography, not in angiography, but you can see this in intravascular imaging, and you can see that you're causing recoil and problems itself.
And now you're done with stenting, you're re-IVUSing, is that correct?
So after doing the pre-assessment, we do stenting, or we do upfront modification of the lesion. And when I ever do a modification, even if it's a stent or a road ablation or IVL, I check if I created what I want to create. So talking before the stent, if I do calcium modification, I check if I have created luminal gain, if I have created cracks in the calcium, and then I go for stenting if it's so. And after stenting, it's important, and maybe that's the most important thing, to check your result. Even if you feel confident and you have a great angiographic result, you have to check and follow an algorithm for post-procedural, post-PCI assessment. So talking about this, you watch for edge dissections, right? You watch for proximal and distal edge dissections, and you watch that you hit the lesion, right? That you have not geographical miss. So this could be a thing that you put your stent where you thought it would be right, but the plaque burden and the worst enemy there is lipidic, in my honest opinion, because this can rupture, this can cause stent thrombosis at the edges and closure of the vessel. So check for this, check for edge dissections. So this is also the M in the MLD max, in the max algorithm, medial edge dissection. After this, if you ruled out edge dissections, you go for apposition. As I told you, if you have a long lesion, you have to adapt your stent, and you have to take care that your stent is reaching the vessel wall. You look for apposition. Maybe the most important thing according to data is then the expansion of the stent, that the stent is getting to this volume or lumen. the minimal stent area, which it is supposed to be, right? So this is super important that you expand the stent well, because this is the major fault or the major cause of causing target lesion failure or stent failure.
Absolutely. And on average, how long is it taking you to IVUS that stent in minutes or seconds?
So putting the probe in and pulling it back, it's 1 minute. Because you have the probe on the shelf and on the table. The worst thing I see when I'm proctoring or looking to colleagues, they have the probe and they know, okay, it's 1A indication by guidelines, but they don't use it right. So if you have it on the table, use it pre and use it during, and use it post. So I don't tell everyone if you do a DK crush that whenever you recross with the wire, so you have to do 6 OCT runs.
Right.
So this is not feasible, to be honest. But if you're unsure that you recross with the wire not correctly or you have problems, use your IVUS or OCT probe then. But most important, and if you'd ask me the question, if you can only choose it once, so I would choose it post-PCI. But if you have it on the table, use it whenever you want to, right? And it's just 1 minute taking off your time, but saving the patient a lot of time afterwards. And maybe even you not getting up in the night to get the patient in ACS in the night because of stent thrombosis or target lesion failure.
100%. And, if we have to be comparable to coronary bypass graft surgery, we have to get the best outcome of a stent. I mean, we always get, not always, but one of the criticisms of stents is that you have to come back. Well, not really if you use imaging or much less frequently. So that's the downside. Now, at this point in our episode, I'd love for you to enlighten us about the 3 most recent intracoronary imaging studies and what you've learned from them and how did they change your management recently?
So talking about guidelines itself, there's a lot of studies itself. There's a lot of studies.
Your 3 favorites.
I have 3 favorites. So I'm 3 favorites because it's covering almost everything. Is the network meta-analysis of intravascular imaging by Greg Stone, published 2023 already. It was renewed and showing one thing, that according to every intravascular imaging publications, there is a reduction in target vessel failure. There is a reduction in death, in total death and death caused by myocardial infarction. So this would be the easy question, the easy answer for this question. But talking about recent publications, there is the sub-analysis of the Eclipse trial. To get everyone aligned, Eclipse was about calcified lesions and preparation with orbital atherectomy versus conventional NC balloon therapy. And this trial was negative according to what the investigators investigated, orbital versus NC balloons. But there was a sub-analysis because 2/3 of every patient had OCT or IVUS in this trial. And what the trial showed in calcified lesions is that there is an enormous reduction of target vessel failure. If you use IVUS and OCT, there was no difference between these 2 technologies compared to angiography-guided PCI only. So this is a trial definitely you need to take into consideration. And in my honest opinion, this will change also guidelines, the next guidelines or updates, because this complex lesions, and in particular the European guidelines says there is no calcified lesions integrated. But in my honest opinion, every PCI, modern PCI, should go with intravascular imaging in calcified lesions. So the 3rd trial is ADAPT-DES, the biggest trial with over 8,000 patients going onto randomization 1-to-1 to angiographic guided PCI and intravascular guided PCI done with IVUS. And there is a reduction of myocardial infarction by 38% and most astonishing thing, stent thrombosis by 53%.
Wow.
So shows us once more that there is a huge benefit of IVUS in intravascular imaging.
Excellent. So, I mean, all of us, when we're passionate about it, we think about that case that we did where angiography looked perfect and then you IVUSed and this absolutely changed your management. Can you think of any recent cases in your mind you'd like to give us an example of how IVUS has changed your management?
Yes. So I was changed my management in doing osteal lesions, and the one of the Achilles heels of interventional cardiology is the ostium or lesions in the left circumflex, or lesions even in the LAD. So and there is people, and there was me trying to nail the ostium, but this is super easy, not super easy. It's super tough to do it in angiography. And even if you think you do it right, if you do intravascular imaging, in many cases you see that this is not only a disease of the ostium of the LAD, but it's also a disease of the left main. So this is tending me, when I use intravascular imaging, not to nail, but to cover then the left main itself. So you don't have to cover the left main if it's only distal left main and you have a long left main. You don't have to cover it up to the ostium of the left main, in my honest opinion, but do it right. At least what your shortest pot balloon is in your shelf, to do a proper pot in the left main, and same for the left circumflex. So this is one of the major criteria that changed my style of PCI. And another thing is where you see this haziness in angiography at the stent edge, and you see, okay, put another stent. But if you do IVUS or OCT, you can see that what the thing about it is, what the reason is for this haziness. And then you have to stent, or sometimes you don't have to stent. If it's not a medial edge dissection, it's a little edge dissection, less than 30 degrees of an arc, you can leave it there without putting additional material, putting additional things. And using DCB also is a thing where I think intravascular imaging is essential, because you can see lumen gain, you can see what you have done to the vessel, and leaving nothing behind, but leaving at least a post-procedural after DCB intravascular imaging run behind.
And if you compare your practice now with 80% IVUS or OCT versus your practice, let's say 5 years ago, would you say that IVUS made you choose larger stents these days than you used to?
Yes.
Do you feel like, yeah, absolutely, by 0.25, 0.5?
Yeah, at the beginning of the intravascular imaging career, definitely, right? But doing this 20 to 50 cases, you see that there is no LAD less than 3 millimeters, for example, as we talked about. So this changed. So according to numbers, it's barely hard to say if it's half a size. So not shooting a 3.0 but 3.5. But in the left main, it's even worse, right? Where you put always a 4.0, right? But you see that there are left mains going up to 6.5 to 6, where you have malposition, and you can discuss if malposition is a super worth thing. But this can make your life much harder if you have to get in with the wires, doing abluminal wiring. And this is also a thing where intravascular imaging, I love bifurcation PCI, if you have to do it with 2 stents, you have to get sure where you cross, that you crossed good, and you are not crushing your stent. So, and we have this talking about data, and another trial is the October trial on bifurcation. And there is also sub-analysis in this super high experienced centers from Denmark where the trial was done, that a lot of cases had abluminal wiring where they recognized afterwards in the arm, and had longitudinal stent deformation. So if you don't repair this, there is an upgoing in MACE. So, and this is what you can see and train your eyes with intravascular imaging.
Absolutely. Now, going back, if you had to do it again in terms of learning IVUS from the get-go, one mistake or something that you would have done differently now, what would you advise an early career interventional cardiologist who hasn't been exposed too much to intravascular imaging, and something to avoid doing at the beginning of their experience?
Don't let anybody rush yourself, right? So you need some time, and you will get the feeling of wasting time, and people saying, okay, we have to do 6 additional cases on your cath lab table. Why is it taking so long? And this is cath lab stuff, right? So, but this is a training for the whole team. So the best thing is if the nurses and the lab professionals in the room or outside can do the measurement for you, or you can explain it live. and see, okay, do a measurement a little bit more distally. So this is a positive thing. And then you're getting up in speed. And I'm truly convinced that you have cases where you choose the right material, talking about calcium modification. When you use intravascular imaging, you use your tool right and you will be faster than without intravascular imaging. A pitfall is that you're getting in a rush, doing a run, not looking on minimal lumen area, don't looking at the morphology and not completely looking at the correct length, and just doing one more shots, putting dye in the patient and trusting your angiography because you say, okay, I did angiography and angiography is always right. No, it's not. So, but you have to mix. So one thing is also, if you start, maybe you look only on IVUS, as you told me, you choose 2 big stents, always compare it to the angiography. Does it make sense, as you told, to put in an PDA, a 4.0 stent? No. Something should be wrong in this, right? But you have to find the balance. So
absolutely, and that's super important. One thing you said at the beginning, when you have the incorporated system, the IVUS, if you have the chance to convince your hospital admin to invest in that, you would gain so much time by taking over the measurement immediately. You go to that little iPad and boom, 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 you're doing your measurements yourself. You're not asking someone to move right or left, and you take away that component that wastes time.
And I think even you're using less material, right? So we all know this rotor regret thing where you have balloons going up, and the lesion is not evolving. You have no luminal gain, you have no success, you cannot cross. Intravascular imaging is helping you choosing from upfront the right tools earlier, faster, without using unneeded stuff, right? So if I cannot cross with an IVUS probe, also a tip and trick, I would never use an IVL balloon, because this IVL balloon will also not cross. So take an upfront other technique to make your IVUS probe going, and if you can cross it, shock it if you want to. So yeah.
Excellent. And to conclude, the ultra-low contrast PCI or zero contrast PCI, obviously it's impossible without intravascular imaging. What would you advise people when they start into that field? Do you advise them to apply IVUS in normal renal function patients or every single PCI? What would be your advice when it comes to that?
If you're starting a center, or you would start your expertise in ultra low contrast or zero contrast PCI, you need to start from somewhere else, right? And this could be more simple cases, but where there's also a need of intravascular imaging. And then a tip and trick for IVUS, in my honest opinion, is, and for ultra low contrast PCI, is put additional wires, right? Because in the pullback you can see where the wire is coming from. So this is the first diagonal, the second diagonal, or if you do it in left main. So this could be beneficial to know in one angiographic shot where this wire was put, and in the pullback you see where it's coming in the picture, in the longitudinal or in the actual view of the IVUS. So this is a tip and trick doing ultra low contrast PCI, but you have to be very good in IVUS, in image acquisition and analyzing, to use it then in ultra low contrast PCI. It's learning curve, right? It's all about the learning curve.
And early on, honestly, when I didn't feel comfortable with what I was seeing, just asking partners who have had more experience, it really helps getting you out of trouble, especially if you're trying to minimize contrast. Well, this has been really very enlightening. I really enjoyed that, and I'm sure our audience would like more of these episodes. But thank you for your availability. It's 10 p.m. right now in Hamburg, and I really appreciate you being on that show, and I'm looking forward to have you more and more in the future. Any last words of wisdom for our interventional cardiology community?
Yeah, first of all, thank you for having me. And the last word of wisdom is maybe just use it, just do it. You can do nothing really wrong. You can only do it wrong if you don't use intravascular imaging, in my honest opinion. Ever think about not just use it because of an 1A indication, and if you have it, you have to use it right. It has no healing forces and no unicorn dust on the IVUS or OCT probe itself. You have to see, you have to then react, and then you have to treat it right. So it's being proactive is the thing on PCI. I like most proactive PCI, not react to things. So, and you can only be proactive if you use intravascular imaging. So come over the burdens that there are and the barriers that they are, but do it. And if you do it, you will never stop doing it.
So on the just use it, we conclude, and thank you very much. We'll see you soon.
Thank you, Hady. Bye-bye.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
On Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hady Lichaa
And Sami Seifo.
Our production team is led by Kieran Gannon,
Aaron Bowles.
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.